the first case, Vihan, a 5-year-old boy, was brought by his mother in the OPD with complaints of running nose and mild grade fever since morning. He had mild URTI and was breathing comfortably. However, the pediatrician noted that the child was not responding immediately when called by his name. So, what you think about this? And the options are: evaluate hearing. Child was too attracted to toy car and hence the child did not respond. Consider autism spectrum disorder. Parents feel that he was too bored waiting in the reception and now he's playing up.
So these are options to vote. Voting, please.
5 years, 5 years. So maximum number of the audience, they think we should consider autism. Fair amount of people think we should evaluate hearing.
Go back to the case, please. Because many people did not read it actually. That's why hardly anybody voted. Yeah. So let's go by the first option, which was evaluate hearing. How many would say that that is the right thing to do and why? Yes, somebody can say why. Yes, sir.
In OPD, hardly we get time in a busy OPD, and at first only if we say to the parents that I am suspecting autism, so the parents will never come again.
Big round of applause. Most
That's
practical
honest
practicing pediatrician. Excellent. Art of practice.
This is
Superb.
an honest opinion.
Yes, anybody else? You are right. Anybody else? Yeah, why hearing?
Hearing should be assessed first, then only we can go further. And he is not like very active child jumping here and there that we should go for any other thing. So we should assess the basic developmental things and then we should move over.
Okay. So if he's jumping here and there, it's like Jitendra, then we can think something else. Okay, great. Again, at 5 years, why would you think, but till 5 years, can hearing be missed? No, let's ask. Let's ask. You are right, but so we will do it. But what do you think? Till 5 years?
Or whatever but the symptoms. At the same time, she is going to give us in the history also that this is the part. I think this is very important and you require to explore. Once you have an history, the child has got a delayed probably hearing or some impaired hearing, you have to explore on that and then you can come to the conclusion as far as the autism is concerned.
So the conclusion actually is that more detailed history is required here. But in hearing, it need not always be congenital hearing loss also. It can be acquired hearing loss, and mild hearing loss is more often missed than detected. So even at 5 years, that's why we purposely put the age as 5 years. But remember that you could have missed that. And what's most important is the history here. So somebody wants to go ahead? Next slide, please. Yeah. So what else would you have liked to ask in the history that Dr. Bipin Shah sir said to that mother? Before, so hearing we have understood, we have spoken about it. Also on history, how could you have suspected that there is a hearing loss?
Speech.
Child's interaction with the mother, whether there is a history of speech delay. Eye contact.
Social, how he is behaving social with the other child.
Okay. So whether he is following the command or not. So let me just give you an answer. He does not follow commands. But if the mother does gestural commands, he is able to follow it.
That
Then
is sign
what?
language.
Yeah. So then what is higher? Likely that there is a hearing problem. But if this child does not even respond to gestural commands, there is no good eye contact, there is no good non-verbal communication, then probably you might think, but I still don't want to use that big word. What about point number 2? Nobody answered that. Why not? Go back to the first case, please. Or that child has bechara cough, cold, fever since morning, mild, yeah, actually, but breathing comfortable, but unwell since morning. And doctor is calling out to him. Why will he look? He may not look. He's irritated. He's waiting outside. What do you think? Possible or not possible? So the point is, don't always jump to autism. Bipin bhai, मैं हूँ लेकिन हर child autism नहीं है. Don't always jump. Let it be. What is important is what. So the point is, what he said is right. Take a more detailed history. Next slide, please.
Just a minute. We could also look at how he is playing with that car. Is he interested only in the wheels of the car, or he's playing with the total car?
Excellent. What would matter? Suppose he is playing with the whole car like any other child.
That means his social interactions and sort of playing is in line.
Is normal.
Yes.
And suppose he is playing only with the wheels of the car.
Then probably it will point to the third part. He is interested in something.
Okay. So I won't say, you know why children with autism play only with the wheels of the car? Because they don't look at the car as a whole object which other people use. So that's why that, yes sir.
I would like to condemn the examination of the child, maybe for 30 minutes, 40 minutes, till I am satisfied. Time pass in that extending the examination and observing the child, and that will give sufficient clue.
Absolutely. Well, that's the ideal thing to do. Let's go ahead. Shrikant, take over.
So this is the additional information. So the child kept on fiddling with the tail of the toy dog which was kept on the desk. Upon inquiry, mother told that child is smart and he can open his favorite nursery rhyme on his smartphone and can even recite it at times. However, he rarely engages in to and fro conversation with mother. He likes to play alone with his toy cars and gets upset if somebody touches or changes the way they are kept. He speaks but largely keeps repeating nursery rhymes and alphabets unnecessarily. With this information, what do you think? And these are the options. Refer to developmental pediatrician. Refer to occupational therapist.
Barkha.
Refer to speech therapist. Take a detailed history, examine the child for dysmorphology, examine neurological examination, and refer to developmental pediatrician.
Okay, you can start voting now.
So what our friend said influenced everybody. Shrikant, go ahead.
So the next, so here we, the correct answer is number 4. We should examine the child and look for subtle clues of some significant underlying disease, like there is some dysmorphic faces, childlike fragile legs. So there may be subtle changes, and then we have to pick up, and the underlying disease needs to be treated, and autism is a comorbidity of that disease. So that needs to be addressed, and role of the general pediatrician is important to pick up these underlying causes. And after ruling out and examining the child, if the pediatrician still thinks that this is likely to be just autism or social developmental delay, then he can definitely refer to developmental pediatrician.
Thank you so much. But I am shocked that nobody actually answered the truth, what actually is being done. The first 3 are actually being done, yes or no?
First was, we have patience, ma'am. Yeah, yeah.
All right. So what would be the problem referring to a developmental pediatrician directly? The biggest problem is patient won't go. He won't go because he feels if I go there, I'll get a diagnosis. What does it mean is that he's still not ready to understand what is wrong with my child that will actually need a specialist further. And that's why what Dr. Shrikant said is very important. Take a detailed history. Like he said, examine, you will get dysmorphic features or you will get any other general systemic examination. At least when you are engaging with the child on that point, away from the cough, cold, fever, the parent sees कि doctor इतना ध्यान दे रहा है ये सब examination, clinodactyly है कि नहीं, shape, all that he's seeing means he's looking at something. If you don't do that, and if you just refer to the development pediatrician, it may indicate some other reason for referral. So you need to spend time to do that and explain this to the parent. Yes.
See, it is a questionnaire which gives you another 20 questions. The parents are more convinced that all these things are fitting in these questions. So then we are more inclined to take professional help.
Absolutely right. Any child between 16 months to 30 months, please, please, please do an MChat. Don't try to analyze how MChat is done. Just Google MChat online, free. On your mobile phone just now, you will get the questions, you will get the result also, and you can print it out and give it to the patient and charge also. And the site doesn't charge you anything. But by doing that, it actually makes the patient go through those 20 questions. So it makes the patient realize what you're saying. Yes, sir. No, actually no, nothing verified, but even sometimes beyond 30, 32 months, even if you do it, it's basically anyway a screening tool. Never use a word of diagnosis after that, never label the child. But when you go through these questions, at least the patient is understanding where you're heading to. What would be the problem referring to therapist directly? Why would you need a diagnosis, sir? All right, which means without a diagnosis, just doing a therapy may not be a good idea. Very good. Anything else? Do you think there can be a problem also? Unplanned?
Developmental pediatrician will be able to plan the therapy, what is first and what is second, while occupational therapists will do in or his or her own way as to how to increase the capacity in building.
Absolutely right. Anything else?
Is not only require occupational therapy, he will require a speech therapy, require this. He may require along with drugs also, medications also. So it is not only one trick. It's probably a syndrome. We said there are multiple things. Everything needs to be.
Samir, what we all have experienced in our practice, that whenever we break some suspicion to the parents and ask them to approach a developmental pediatrician, there is a time gap interval. Sometimes it takes 6 months, 9 months. And some of the families, they readily go for therapy without understanding what is the need. So at least the child is put on the path of the treatment. How do you think about it?
You're right. My question would be, what do you do with the family till then? You can do so much to guide the family.
No, but there are in-laws, there are...
No, I understand. But till then also, can you give some advice to the parent? ठीक है, नहीं जाने का है development pediatrician के पास. मैं तो लिख रहा हूँ paper पे. But can you still give them some good advice? Most important, avoid screen time. Make it almost zero. That's the most important message you can give. Very good. What else?
See, Samir, one thing is there. Now all schools before admission, they ask for this. So one of the ways of pushing them to go earlier is I tell them that your school admission is due now. You better finish this, because if the child is not going to answer his name in the interview, they will not take him in the school.
Very nice. Anything else you can help the family with? Give majority time as parents to the child, interact with the child. Yes?
Yeah, especially the mother should interact with the child much more. Yeah.
All right. So one of the parents or both the parents should keep interacting with the child.
Whatever you observe, in fact, not been noticed by the parents. So whatever the time they are going to take, just ask them to observe something like eye-to-eye contact. They have never probably realized that this was missing. So you make them to realize that and see that if you are convinced, then this is the place where you must go and see that you can go ahead.
Absolutely. Ask them about the screen time. Yes, Dr. Kangal, sir. Okay, wonderful.
Dr. Barkha and Dr. Shrikant, we have 10 minutes more to spend.
So we'll conclude the first case with the understanding that even if the parent is not willing to go directly to the developmental pediatrician, there is so many things you can do and you can evaluate. There are children who may have a hearing, recurrent hearing infection, ear infections, so many other things as pediatricians we can do that needs to be looked into. Next case, please.
Okay. So we'll go to the case scenario 2, which is a 7-year-old male child studying in grade 2 comes to you with complaints of poor scholastic performance. The typical day say, "Mera bacha padhai nahi karta hai." Just a quick on what will you think in this situation. There are no options here, but randomly, what are the thoughts and what is the quick advice? Because there's a quick OPD going on, rushes. Then everybody has this complaints post-COVID that you're not studying. So, just what would cross your mind?
First and the foremost thing is the medium of instruction. The very common thing that all the parents and the brother, sister, the elders are talking in Marathi and the school child is sent to the English medium, so there is a problem. Second thing, the child has some hearing problem or eyesight problem, or child has some illnesses which are very obvious, or hidden nutritional deficiencies, they have to be screened. And if the child is distractible, whether he has evidence of attention deficit, and there are some socioeconomic factors like marital problems and the marital disharmony and the parental illness, economics, etc.
Perfectly.
Excellent.
So it's
Excellent list. Big round of applause. He's covered everything. Very nice.
And post-COVID, what we have noted is that children are from nursery or say junior KG, say senior KG have gone to standard 2. So there's a big jump, and initially they were being trained on this online this thing, which was hardly any training, and now they are expected to just jump two grades. So that's the problem.
Absolutely perfectly.
Another very important aspect is slow learners. If the basic intelligence of the child is low, then we are at a loss.
Superb.
So the message here is that everything is not.
Just one more message. Aaj ke baad, let's not forget to pump the iron.
And also we should find out whether child is otherwise intelligent. Because if he is doing everything others properly and whether he is stuck to mobile or iPad, looking at something, he will not be interested in studies.
Because of this COVID era, as we have seen, many of pediatricians have very less OPD numbers. Okay, and we have got ample time in the office practice these days. So I think we should say to it that we call him 2 or 3 times. एक बार urine बोलो, दूसरी बार CBC बोलो, iron and etc. And just keep observing child at least for 30 minutes. I think start taking social history, social pediatric. In first visit, rule out organic pathology. Second visit, rule out these problems. And third visit, I think we can come fairly to the conclusion.
Very good.
So I think the conclusion here is that all academic problems are not only LDs or not learning disorders, ADHDs. So it's also first rule out the environmental factors, rule out the vision, check for that also, and then when other things are not working, then look out for proper neurodevelopmental concerns. So of course 3 months.
One second. So maybe even if it is a COVID issue, you will wait for some time and you will guide the parents that look, since he has missed out, like sir said, for the last 2 years.
They have got also concept probably going to developmental pediatrician for autism. The charges are fairly high, the things are very costly. So that also probably requires to be given thought as far as the management is concerned.
Okay, Vivin bhai, thank you. So all these causes, what both of you said, they can be worked on by the pediatrician in the OPD, including pumping the iron. But if it doesn't help, then 3 months later this happens.
Okay, so 3 months
school
later.
Environment, in the peers environment, is bullying in the school, if he is afraid of the school, sometimes that may also matter.
All this needs to be looked into. We advise the parent that, but look what happened 3 months down the line.
So 3 months down the line, parents come back saying there's no improvement. Of course, we've asked to give a healthy atmosphere, give more positive appreciation, decrease the screen time. But there is deterioration noted, and now the child has refusal to go to school. Complaints have increased from the teacher. That means the child does not sit, has become more aggressive. Here are the options, if we can take that quickly. Option 1 is speak to the child, see if he has anxiety going back to school post-lockdown or he is missing his home. Take a detailed history is the option 2 of his school's days prior to lockdown. Were there any complaints then? And option 3, ask the child to read his books in front of you if you have the time. Go through his written notebooks. So quick option.
So all of these, any of these could be right. There's not necessarily one right answer, but let's see what you think is the most important thing you would do.
Okay, so that's for you. See, we have a 7-year-old child here. The first option that comes is, 22% people have said that speak to the child and look for anxiety. But always remember, we have a 7-year-old child here who may not really give you the history of what's making him anxious. So I know we tend to talk to the children, but this is one strategy which may actually fail in your clinical practice, which is there. The second is take a detailed history of his school days prior to lockdown and was there complaints there. This is actually one of the most important thing that is to be there. In any neurodevelopmental concern, history plays the most important role for the diagnosis and to come actually to a conclusion of what the child is suffering. When you know right from the beginning that this child was struggling even in his even in the pre-COVID days, you know that this is more of a neurodevelopmental concern rather than having an environmental or post-COVID coming as a add-on factor. So this is the most important thing. The taking the books and assessing is just an add-on which helps you to understand the level at which the child is having a lag. It will not really help you to know what is the basis for all these academic concerns, but of course the level which will have a lag. And there are some subtle signs which are there when you are assessing the books. So you'll tell us the signs.
So basically there is a pattern of errors that is seen if the child has a dyslexia or a dysgraphia. We all know that the reversals, the mirror images. So when you go through it, you will find the patterns in all the books, not just my favorite teacher or my most hated teacher subject. So that is what we need to look for. Go ahead.
So the second actually is the most appropriate answer in this case.
So why we are saying that? Because parents, नहीं, वो तो सिर्फ lockdown के वजह से ऐसा हो गया. All complaints are attributed to the lockdown. And that's why the message we wanted to give was, take history before the lockdown. दुनिया था, lockdown के पहले भी ज़माना चल रहा था. So take history of that. They'll tell you, तभी भी problem था, लेकिन इतना नहीं था. लेकिन था ना, it means there was some problem which got aggravated by the lockdown. That's the message.
Okay, now the teacher has reported, so the additional history is coming out, that he does not pay attention in the classroom, writes slowly, has spelling errors, difficulty in reading and comprehension noted. They have asked the parents that you get a certificate for the child. I think all of us encounter this and most of us are seeing that in our OPDs. Parents feel that no, this is only a lag of 2 years because of the COVID and online schooling. They have come to you for an expert opinion. What would be your line of action? Refer to an institute from where the certificate can be obtained and just carry on with the OPD. Refer to a developmental pediatrician since he has a problem. Take a detailed history, examine the child, review noted, and if concerns noted, refer to an institute for certificate. Also advise to stop screen and start remedial education at a private school or a setup. Take a detailed history, examine the child, and if concerns noted, start a stimulant medication to improve the attention span and ask for a follow-up after 1 month. Okay. So we'll just discuss.
Let's take a, yeah.
You
Go
take
ahead.
some. No, please.
So basically most parents would say कि हमको और कुछ नहीं करने का है, certificate ही चाहिए, and if they are from an SSC medium, you'll have to send to KEM, Sayan, Nair, JJ. So that's one point of it. The second and third points are what we are talking about. In this child, you saw that he had specific problems even before COVID. They got worse after COVID. And then he has some specific patterns of problem while reading, while writing, as was noted. So in this case, we are thinking more in terms of a learning disability or a dyslexia, dysgraphia. But the point here is just referring for remedial education is not going to be the solution for the child. Why? Because there may be a comorbidity of inattention or ADHD or hyperactivity. Or by now the child has already got the comorbidity of anxiety because of the last few months what's going on. And hence only doing a limited remedial education is like doing a limited speech therapy for a child with autism. Next, fourth point is take a detailed history. This is what we are talking about, a child who has hyperactivity, inattention or ADHD. If you start just a stimulant medication, his concentration may improve, but his basic problem with readings and writings are not going to improve, or his anxiety is not going to go away. So what it means is it has to be referred to a place where the developmental pediatrician can plan the entire treatment, what goes first, second, third, and then start.
Yes,
I think
so
Samir bhai, we are time up.
Yeah, we are done with
one
it.
last.
Just one point, important point we wanted to discuss about the first case. So the first case we saw that 5-year-old child was under consideration for ASD, and ultimately the child was diagnosed as ASD. Now the child's father says, I have a 2-month-old child and I don't want this second child to develop autism, and he is asking what can be done for that. So this is an open question to audience. So
All right. So basically, I think this must be happening. Nobody at 2 months can predict whether this child has autism, though we know that 10% more chances. But what you must keep in mind, of course, is to always do a vision and a hearing evaluation. Second, check for all the domains. Third, like she said, take a detailed antenatal, perinatal, and postnatal history to look for any high risk factors related to development there. And finally, what is most important, tell the parents, don't show the child TV, mobile screens and those gadgets, and keep interacting with this child as often as possible. And finally, keep him on a regular monitoring post-OPD follow-up. I think if we do this, that's the best service we can do to, if not completely prevent the autism, but at least mitigate the effects of autism.
So nurturing care for early childhood development probably is the key for prevention of the autism, probably. And mother's love and attention is probably the best therapy that we can offer to any child who will not develop autism after that.
Thank you.
Thank you so much, Dr. Sameer, and both of you. It was really lovely. Feels nice listening to you again and again. A gentle request to all the delegates, kindly make sure that your voting pads are here before you leave the hall. We have actually paid a significant amount of rent for each of the voting pads. So by mistake, they should not be, just cross-check that before leaving. Also, don't leave without having the high tea. It's really a nice, delicious high tea with snacks. So before leaving at the end of the session, it's arranged downstairs where the lunch was served. Sir? Okay, so moving on to the next session, rheumatology is not an illness. It is actually a part of a pilgrimage. This was very well described by somebody, Lisa Koppen, who was a very senior rheumatologist. And to understand the aches and exhaustions of the inflammation of muscles, bones, tendons, joints, I now call upon Dr. Sikha Agarwal, our young and dynamic EB member and a rheumatologist, to please present a case on the same.
Thank you, ma'am. Thank you. And in this session, we'll keep it very brief, matlab, in the sense very basic, which I think Ambedkar sir must have been teaching for so long. Just examine properly. You will get the clues in that itself, a history and examination. And it's more of a pictorial examination, pictorial slides that I'll show here. And you can have the voting pads in your hands. Okay. So we come to the first case. This is a I think, 2-year-old child. 2-year-old child who presents with history of fever for 4 days, along with there is oral ulcers and throat pain. So one of the very common presentations that you see in your OPD, that could be so many things: viral exanthems, hand-foot-mouth disease, anaphthous ulcers. So these are the things which you can think when the child presents first time. But if the same child presents in your OPD, sitting in your OPD, now for the 4th time in the last 5 months, each time with similar complaints. Fever, which lasts for 5 to 6 days. This is associated with oral ulcers and throat pain. So, will you think of something else here? Voting, please. SLE, PFAPA, Behçet's, candidial ulcers. Anything? Voting, please. Yes, sir. Sir, did you?
Yes. Second one.
What did you? So why?
That's full form of PFA. It is periodic fever, aphthous stomatitis, and that thing.
Yes, sir. So here, that's what we are focusing at: periodic fever, aphthous ulcers, pharyngitis, and adenitis. So there are 2-3 things which can struck to your mind. One is the recurrent aphthous ulcers, But the recurrent aphthous ulcers usually do not come with recurrent fevers and usually do not have these kind of periodicity. So here we see every 4 to 5 weeks, the child is landing up with a fever. He's having oral ulcers, he's having throat pain, means pharyngitis, and if you examine, there is an lymphadenopathy. I could have given some more history in blood investigations. If during the fever episodes you find that the CRP is high, there is a neutrophilic leukocytosis, it points more towards a periodicity. In between, the child is well, the child is growing well, feeding well, everything is well. Think of that it can be something which is periodic fever. So here, PFAPA seems to be a more appropriate diagnosis here. Okay, so we'll come to the next one. So the results, first we'll see the result at least. So there are some people who voted for Behçet's. So in the next slide, we'll see why not Behçet's here. Is anybody like to comment why Behçet's? Who voted for Behçet's? If somebody would like to comment. Okay, we'll go to the next one. So 10-year-old child presents with history of fever for 1 month. There is a history of associated oral ulcer, which is leading to inability to open the mouth adequately, so painful. He had similar episodes in the past, but not so severe to land up in the hospital. This time there is also weight loss, appetite loss, there is some arthritis in the right ankle, and there are also lesions on the skin as well. So here we see, if you can see, there are lesions in the oral mucosa, which are like, and the child is also not being able to open the mouth properly. So, votings please. And we have the voting. Now. So, SLE. So I'll have to ask someone. No? So you voted?
I voted for first, systemic lupus.
Can we see the results? Okay, so maximum voted for 67%, some voted for 27%, and some voted for the rest. So here I would like to say that when you are seeing an oral ulcer, you see a few points. You see whether the ulcers are episodic, recurrent, or they are persistent ulcers. You see whether the ulcers are painful or painless. So lupus usually, not 100%, but 80% have less painful ulcers. And Behçet's have very painful ulcers. Similarly, aphthous ulcers are painful, but they are not associated with recurrent systemic signs. They are standalone aphthous ulcers. PFAPA will have more periodicity. Just simple history, whether periodic, whether episodic, whether persistent, whether systemic signs or not. Here the child is having ankle swelling, some lesions on the skin. So Sir is correct in mentioning SLE as well. So those who voted for SLE, it's a right thought, but here in this patient, because I pointed it's a very painful ulcer, the voting for Behçet's goes more. So similarly, we'll come to the next slide. A 9-year-old girl, history of fever for 1 month. There is associated history of weight loss, appetite loss, hair fall here. When examined, has oral ulcers, which are not too bothering for the child. And these are the oral ulcers. So now, so voting. So I think we can directly see for the results here. Results. So SLE. So it was very obvious. So why I mentioned here, because here there is a palatal ulcer. So a palatal petechiae, you have to see whether it's involving the keratinized mucosa or the non-keratinized mucosa. Aphthous ones is usually the non-keratinized one. lupus is very characteristically known to have palatal ulcers. Not, of course, it should not be there to prove lupus, but if there is palatal ulcers, you definitely have your antennas up whether it can be lupus, especially when the child is having systemic symptoms. So this is what I wanted to focus on. Different kind of presentations, even without investigations, can narrow your differentials, and of course investigations can help you disprove it. So one last case we have here. This is a child of lupus on immunosuppressive therapy, now complaining of fever, oral ulcers, decrease in appetite, and these kind of ulcers. So I'll not give you the options. What? No, it can be a lupus flare. Can it be? Why not?
I don't know much about lupus flare, but I think this is looking like, because there are these small satellite kind of lesions. There is basically bleeding that's happening from, there is
yes. So yeah, white patch is one thing. So lupus flare will also have similar, but here we see there's so much difficulty in opening the mouth. It is a painful ulcer. And he's of course on immunosuppressive therapy. So candidal infection is the most important thing. Of course, with every infection, we have to rule out whether the child is in flare or not, because there can be both together. So just a simple examination can help us. Voting results are showing. We have not voted. No? So common is always common. Aphthous ulcers, herpetic ulcers, nutritional deficiency. In the third case, like we had painful oral ulcers, there was a cheilitis as well. So anybody could have thought of nutritional deficiencies as well. A geographic tongue and enlarged tonsils when we are seeing in a young child is very common. But rare is intriguing, and that's the reason I'm a rheumatologist. So if the ulcers, what if the aphthous ulcers are recurring? Then you should think, is it beyond the normal aphthous ulcer? What if the ulcers are really angry looking? Like we saw in the candidal infection, they were angry looking ulcers. Even sometimes Behçet's have angry looking ulcers. So we should think beyond. If there are systemic signs, definitely we should think beyond. If there are systemic signs, it cannot be just something which is like an aphthous ulcers. We have to rule out why these systemic signs are coming. And if there are no tonsils, so we always see enlarged tonsils. 10-year child in the tonsillar fossa, you see no tonsils. What is one thing that will come to your mind? Immunodeficiencies, very correct. So immunodeficiencies, if there is oral ulcers and if there are other infections as well, then you should think of immunodeficiency. There is no tonsils, so B cell deficiency, XLAs can be a possibility. And now in the COVID era, we have seen if there is no taste. Yes, ma'am.
Aren't aphthous ulcers also recurring to an extent? Because I know of my family members, some of them who keep having maybe once a year or once in every 2 years, not very closely recurring.
Yes, ma'am. Recurrent aphthous ulcers in adolescent, around 8 to 12 years or 14 years is very well known. And they have found to have an HLA association. They have seemed to be having the same spectrum of PFAPA and recurrent aphthous and Behçet's disease. So not all must be having that, but there is recurrent aphthous ulcer, but they'll not have systemic symptoms. Exactly. Yes, they can be labeled as recurrent aphthous ulcers, supportive management only. But if there are systemic symptoms, then of course we'll investigate.
Dr. Sikha, you have 5 minutes more.
In the same case that Dr. Manglani mentioned, it could be because of vitamin B12 deficiency, like what she was talking about, recurrent ulcers in adolescents and adults.
So
B12.
vitamin deficiency,
B12.
again, B12. So again, cheilitis, that's we see. And if we are seeing anemia along with it, but there'll not be so many systemic symptoms. Then you'll have some peripheral nervous system involvement or chakkar aa raha kind of stuff with B12 deficiency. So those things. So this is, and in COVID era we see if there is no taste again, then we have to think of something else. So this is what, ma'am, I was meaning. So recurrent aphthous ulcer, PFAPA, Behçet's, all have seemed to have an HLA association and a family history also. So we see hard palate, soft palate, benign, angry looking, mucosal involvement, genital, eye surface, everything has to be examined. And skin and mucosa, very important. The mucosa of the mouth's universe, and skin is the mirror to the internal diseases. So it might seem to be something else, but actually it's something else. So you have to look through the mirror to find out the cause, exact cause. So should we proceed ahead?
Yes.
Okay. So it's a 1.5 years old child. So come to the skin, 1.5 year old child, history of fever for 3 days, lesions on the hand and foot. I think everybody in the OPD must have seen this case. Do we need a voting? No. So hand, foot, mouth disease, very correctly. Hand, foot, mouth disease. But now you have another 1.5 year old child, fever for 3 days. There are some lesions on the hand and foot, but you see some subcutaneous swelling on the forehead, and these lesions are some targetoid lesions. Some painful lesions which are on the forehead, which are on the foot as well. Can we have the voting?
At a loss, sorry.
No.
Anybody? Is it acute hemorrhagic edema of infancy? Because we are talking about edema, there is these kind of lesions which look like ecchymosis or like, something which is...
Yeah, so very correct, ma'am. So here, one of the possibilities, of course, there can be hundreds of more possibilities, drug reactions and things like that, which can cause targetoid lesions. But in these options, the best fit will be acute hemorrhagic edema of infancy, where infancy is misnomer because it can happen till 5 years of age. And they typically have those subcutaneous lesions which happen in the occiput, which are painful, which will disappear in 24 hours. Next morning, the patient again comes to your OPD and it's not there. And usually does not have any lot of systemic manifestations. So can we see the voting results? Okay, so dermatomyositis. Let's discuss in the next slide why not. It's not moving forward. Yeah, so we have a 6-year-old child with history of fever for 1 day, lesions on the hand and foot, not painful, along with some joint pain. If I also mention we did some CBC and things which were absolutely normal in this patient. So what will be this one? Voting. Show the voting results. Yes, so enoxaparin very clearly, because if one thing has to be there, the CBC has to be normal. There should be no thrombocytopenia. If thrombocytopenia, then ITP becomes a possibility. Here we are very clearly seeing henoxaparin purpura, which is now called as IgA vasculitis. Last case, so this is a 5-year-old child which has fever for 1 month, lesions on the hand associated with weakness, inability to do her activities, go to school, rash on the face and joints. So I think the only option that is left is dermatomyositis. Why in that case, dermatomyositis, where somebody had pointed at juvenile dermatomyositis, it was just a 3-day history. 3-day history, no weakness, only targetoid lesions, no systemic manifestation in the second case. So that is the reason dermatomyositis is very low. And these are typical Gottron papules. Yeah, Gottron papules, which this child has. And if you turn the hands of the child, it will not look like a 5-year-old child. It will be like more like 11, 12-year-old child, the mechanic's hand that we call. Then there is a periorbital lesion, there's a facial lesion, and there is weakness. So it's very important that we see the mouth's universe, the skin's mirror, take a good history, early diagnosis, some investigations, and leads to timely treatment and less morbidity.
Thank you.
Thank you.
Thank you, Dr. Sikha. That was really a very good presentation. So it is my gut feeling that the last session of the day is really going to give us valuable insights on common case scenarios in gastroenterology. So I invite the expert, Dr. Vibhor Borkar, and we have moderators, Dr. Jitendra Gavane and Dr. Jagruti Sanghvi. No, it works. Battery है क्या क्या? Battery चल नहीं रहा है. देखना. दिनेश. The housey prizes are still there, all of them. So please, after the session is over, you can collect it from me.
Hello everyone.
Hello. Hello.
Hello Jagruti.
Hi.
Vibhor sir, hi. So we have some case scenarios in gastroenterology as we have expert Vibhor with us. So keep your voting pads ready. Let us have first case first. This is a 5-year-old boy, full-term normal delivery, 2.7 kg, delivered by LSCS. There is a bleeding PR mixed with semi-solid stools intermittently since last 15 days. Child is irritable, cries a lot, child was on exclusive breastfeeding, but later 1 to 2 feeds of powdered milk was started as mother felt that she is not having enough milk. At birth, baby was given top milk for a few days and then till mother started her secreting milks. On examination, vitals were normal. The current weight is 4.2 kg and there is no organomegaly.
Yeah, so the audience poll on this, what are the DDs most likely? You could start the timer. Anal fissure, 2 infective colitis, 3 cow's milk protein allergy, or 4 lactose intolerance. Yeah, could we have the poll results? Wow. So we have most of the people who are talking about CMPA here. However, there is 13% of people who have spoken about lactose intolerance. Anyone who has voted for that, can you tell us why do you think it is lactose intolerance? Anyone? Or anal fissure for that matter?
Because there is a typical history of irritability and crying.
So that's why it is 1? Or
I chose anal fissure.
okay,
The thing is that the child is not put on proper weight, that goes against it.
fine. Anybody for lactose intolerance? Yeah.
None of you have mentioned infective colitis. Why so? Any child coming with loose motions and blood in stool, we think first as a infective dysentery, right? Huh? So he is on top feed also, sir. Yeah, 1 or 2 feeds he is taking every day. So why we should not think of infective endocarditis? Infective colitis. So history is going for 15 days and there is no history of fever or at the onset. Suppose this child we see at 3 days of symptomatology. Then it changes to infective colitis?
It is possible.
It is possible. So sir, what is your take?
So this was not expected. See, you have a child who has a history of 2 weeks. So when you are in diarrhea for 2 weeks, the first thing comes, and always we think of infection and is the child is going towards the persistent diarrhea. That will be always the first possibility. It can be something started with infection going towards the chronicity. Then second cause, then whenever there is an infection, always, of course, we need a more history. What was any treatment taken? Any diarrhea initially will be treated like a viral infection. Fortunately, let's hope that child has not received any antibiotic. But if there has been any courses of antibiotics has received and despite that child is having blood in stool and all, then I may think of a CMPA. So CMPA should not be a first diagnosis with the available information. I like to have more information because we have only a single system involvement. CMPA generally think where there are at least 2 of the 3 system involvement, like GI, skin, plus minus respiratory system. Plus, look for any family history. Is there any family history? 10 to 20% can the first degree relatives, might be another siblings, or one of the parents, or the maternal or paternal aunts, uncles, they may have a history. And weight loss may or may not be there at 2 weeks. It can be also present with infective. So we like to have a more history before coming to the diagnosis of infective colitis. Now lactose intolerance, blood in stool, rule it out. It's not the primary. Secondary, as of any malabsorption, it can be there. It can be associated with any diagnosis like secondary lactose intolerance.
So can it be because of lactose intolerance secondary to the infective colitis giving rise to a lactase deficiency and therefore a lactose intolerance?
It will not give blood in the stool
Okay.
because there is a carbohydrate malabsorption. Whenever the blood is stool, I will not think of. And anal fissure, as sir said, many times when you have a liquid stool, the perianal areas can be wet. There can be someone can rub it hardly, and one can get a small streaks, but it will not be a significant amount of. So we need a more history. So most probably, first possibility will keep an infective colitis. Second, maybe CMPA. So what was in this case?
Next slide, please.
No, what was the diagnosis in this case? Only that probably.
No,
So what is the other information?
So how will you confirm this diagnosis? Whatever you have shortlisted, whether it is cow milk specific IG we have to send or stool routine and culture, total eosinophil counts more than 1500, or elimination of milk followed by reintroduction of the milk again.
Can we have the polling?
Poll, please.
Yeah.
Yes.
The results? We have.
Very nice.
So, Dr. Borkar, you only can say in this
So,
case.
as we started from the first slide, CMPA is overly diagnosed condition in Mumbai, and so is the treatment. So first is, okay, we rule out infection. When we got another history of other thing, and that is supportive of CMPA, yes, then we think of a CMPA. Yes, now having that assumption, we are dealing with a child with cosmic protein allergy, probably yes, the right choice will be elimination of milk followed by oral challenge. What about stool routine and culture? So whomsoever have opted for that, so what is the thought process for it?
So this child did have a family history of atopy, as
Okay.
you had mentioned earlier. So there was a family history of atopy and the rest of the history, as Dr. Jitendra mentioned.
So what information will you get it from the stool routine and culture? Maybe any case. Suppose I have another child, and actually the child has an infective diarrhea. So would you go for stool routine or culture or not?
Why would you not go for a culture, ma'am? Dr. Jitendra, you can hand over the mic. Why would you not do a culture, stool culture,
stool culture
in a
is-
child who
should not-
probably could be having an infective colitis? Anyone?
Specific or not
Stool
lead
has
us to any
stomach cells.
diagnosis.
So doctor says that it could pick up any E. coli,
Exactly.
which could not be specific to your diagnosis.
Mostly they will go commensals and don't go for a stool culture. And most of the routine examination, irrespective of the pathology, they will show some increase in inflammatory markers. Blood you can see easily, so there by eyes. So for occult blood we don't need to do. The diagnosis of colitis will be always by criteria of visible blood seen in the stools. So we don't need a stool examination to see whether it is colitis or not. So this child has definitely has colitis. Other options like cow's milk specific IgE, not required for diagnosis.
Sir,
Total
but if
eosinophil
you
count,
do
again
it and if you find that positive, does that reinforce your diagnosis of CMPA?
Yeah, if it is a difficult scenario. If cow's milk specific IgE is present, definitely it supports the diagnosis. But if it is negative, it doesn't rule out the diagnosis. It can be an Ig mediated, can be non-Ig mediated and mixed. In Ig mediated, it will be positive. But your clinical history is so dramatic in Ig mediated. I don't need this test to diagnose. Of course, I will need this test to support my diagnosis and followed by to see the response whenever I am planning reintroduction.
Okay.
And when it is absent, it can be a non-Ig or mixed, it can be absent. So it will not be a first choice in the diagnosis, but yes, it will help somewhere in the management and the follow-up.
So if the like if the cow's milk specific IgE is positive, does that mean that the child will have a much severe allergic response to cow's milk protein, as in like an anaphylaxis or something like that?
So if there is an Ig mediated, then already this response will be like that. In a mixed one, you can get an Ig mediated. This test can be a positive. And when we are challenging, if it is positive, the chances of positive challenge are very, very high. So in this situation, whenever we are clinically, we are seeing the child in OPD and planning a challenge, we see for this serology to get negative and then we challenge.
Okay.
So most easier will be just eliminate and then reintroduce and see again whether symptomatology is coming again.
Day-to-day practice, how should we suspect that a particular baby or a child is having possible CMPA?
We will come it at the end during the summary.
Finish the case.
Sir, is it also true that the non-Ig mediated CMPA may not have the respiratory and skin manifestations that you were talking about?
No, they can have.
So sir, can you let us know a little bit about the oral challenge test, whether we can do it in our OPDs in our general practice?
So the oral challenge test we can do after a month of elimination. So before a challenge, the first criteria is there should be response. Only then we'll do challenge.
Correct.
Provided there is a response, then we can do challenge. But before doing a challenge, explain to the parents that your child can go back to the same symptomatology. If the symptoms are something you are able to manage on OPD basis, then you can do it. But suppose the symptoms are something where the child was too affected physically, significant weight loss, landed in hospital, so parents may not agree to it. So this is very a situational thing. Guidelines will say, okay, yes, you challenge to confirm it. When we are doing, we are treating the patient, we have to take this decision on case-to-case basis. So when you are doing the challenge, the first thing, the recurrence of the symptoms may not be the same the way we had it during the presentation. So the first day of challenge should be very slow and under observation of a doctor, because they can have a severe anaphylactic reaction. So what we do is they ask them in an OPD, let them sit in your OPD area, make sure that you have a facility for any resuscitation. And whenever they get first symptom, first thing is to stop the challenge. If the first day is uneventful, rest of the days they can do it at home for next 14 days, and the amount of the milk that is used, if it is less than 1 year, use formula. More than 1 year, can be pasteurized milk can be used. Less than 1 year, 100 ml of quantity at least, because the dose is also important. More than 1 year, 200 ml in a 24 hours. So give it for 14 days. If there is no response, chances that probably this was not a milk allergy.
So we were, by history, we were having a prolonged history of top feed. So looks like a non-IgA mediated. So still we should take all those precautions of IgA mediated
Yes.
anaphylaxis and all?
Yes, because allergic manifestations can do change. So it's always better. We need not need them to admit. We just want them to be in OPD,
Observe, yes.
under observation. If something is there, we are there
Point
to help the
taken,
family.
so it should be under observation.
Yes, sir. Sorry, sir?
All the formula milk which is available in the market,
Sorry,
they are
our question will come, sir, on that.
Okay, we'll come to that.
So,
no, but they are maybe from buffalo or
Yes.
only cow.
They are
They
bovine
are cow's
protein.
milk based. All the formula that
All
we
are
have in
bovine
the
protein.
market, unless we are dealing with, sir, a soy formula, they are essentially bovine milk based.
Okay, probably that will. The other composition, electrolytes, carbohydrate, these are been. The protein remains the same. The casein bond remains the same.
Yeah, the source is bovine, essentially.
So in this child, should we go for scopy? First option is at the time of presentation, no. Second option is no, we did not
Start
do
the
it.
poll.
Or if there is no response at the management, or fourth option is there is response but to confirm or document the diagnosis.
So we have eliminated milk and tried an oral challenge test. What would you do? Will you also do a scopy?
So
3, if there is
72% people said if there is no response, then we will go for scopy. However, few people feel that there is no need of scopy at all. Vibhor sir, what is your opinion?
So, means, yeah, if patient responds, there is no need, absolutely no need. At the diagnosis, again, it's not required. If the presentation is atypical, like some of the milk protein allergy can present as a hematemesis. Now, this is a very atypical presentation. In such situation, I will need scopy at the time of diagnosis. And again, of course, if there is no response, yes, we are dealing with some other etiology. Only at that time, probably scopy will be required.
So, if the child is responding, scopy is not required. If there is no response, then we should go ahead for scopy. What should we feed this child?
Yeah, is it goat's milk, partially hydrolyzed formula? Please start this poll. Extensively hydrolyzed formula or amino acid formula, or early introduction of complementary feeding in a child like that? Is it partial or extensively hydrolyzed? Can we have the
Display,
results?
please.
Most people have opted for 4, that is early introduction, but there are equal number of people for hydrolyzed formula. So my question to Dr. Borkar would be, what kind of hydrolyzed formula can be given to this child? And if yes, I mean, whether we should give hydrolyzed formula, if yes, whether partial or extensively hydrolyzed, and why?
So once we are entertaining the diagnosis of allergy, then the first two option has no role, absolutely no role. So goat milk, no. So all animal milk has to be avoided. Partially hydrolyzed formula, again, we have to understand that what happens when they are breaking these the proteins. So partially hydrolyzed formula will be having the size of more than 15 kilodaltons. So it cannot treat allergy. So you need a formula where the size will be less than 10 to 12,000 12 kilodaltons. So extensively hydrolyzed formula or amino acid formula may be used when you are trying to treat it and you don't have the mother's milk available. That is the first choice. If mother's milk is there, just ask mother to stop any milk intake. In this patient also, we will stop the mothers to have any kind of milk and milk products intakes also. So that is also important. So she has to sacrifice tea, she has to sacrifice coffee also. She can go with the black tea, black coffee. Other important point is at this 5 months, majority only 1 or 2 feeds were only required by which were top. So why I should spend the money on the extensively hydrolyzed formula?
Exactly.
Very well you can introduce early complementary feeding and go ahead and can save the family's finances.
So he's nearly 6 months, so we can very well go ahead for early complementary feeding.
Sir was also mentioning about buffalo milk, but buffalo, goat as well as cow's milk all have to be avoided.
Donkey, camel, mare, all.
So nothing.
All animal
No
milk.
animal milk.
Yeah. We go to case 2 now.
So for
11-year-old, yes,
So
Dr.
for
Aditi.
how long do we have to wait to see that this child is responding of cow's milk?
6 months or 1 year of age, whatever comes later.
So up to 1 year of age, if the whatever comes later, you have to eliminate milk from the
So
diet.
this child was 5 months, so I'll add 6 months to it will be 11 months. 11 months I may challenge. Suppose I am treating this child at 7 months of age, then I'll wait till 13 months of age.
Okay. A 11-year-old child, this is the second case, comes with fever since 10 to 12 days, 100, 101 fever, 1 to 2 times a day. There is no vomiting, skin rash, oral ulcers, joint pain, swelling or pedal edema. Abdominal pain and loose motions have been there off and on inquiry since the past 1 month. And since the last 2 days, there has been blood in the stools, which has made the parents come to us. Next slide.
So this is the child whose weight is 28 kilo, height is 145 centimeter, is 11-year-old. Vitals are normal, pallor is there, no clubbing, no lymphadenopathy. Per abdomen soft, tenderness in lower abdomen is present, and per rectal examination no fissures or fissulas.
Can we go to the next slide? So what could the etiology be? Have the poll, please. Infective colitis, GI tuberculosis, inflammatory bowel disease, or Meckel's diverticulitis. 11-year-old boy with fever, abdominal pain off and on since the past 1 month, and 2 days history of blood in the stools, tenderness in the abdomen, growth stunting 145 centimeters.
So display please. So 20% think that it is infective colitis and majority people think that it is inflammatory bowel disease.
I'm surprised at this 10%. Why would somebody not think of GI tuberculosis?
Yes.
Can
Why
I
not
have
GI
some?
tuberculosis?
Being in India, this kind of a history
10
of
to
fever
15
going
days
on.
history, intermittent abdominal symptoms.
Blood in stools is less likely.
Dr. Bela is saying blood and stools is less likely with GI tuberculosis. Any
Less
other responses?
Order of symptoms. The way symptoms have been given. First, pain in abdomen, loose motion for 1 month, and fever was for last 12 days, and blood is in last 2 days. This is not the way, means normally tuberculosis presents.
Tuberculosis
Why not
का
infective?
अपना एक धर्म है.
Only 20% has gone for infective. Why not infective diarrheas? Yeah, failure to try is the only pointer. Otherwise, we do get infective diarrheas also, specifically the traveler's diarrhea. There's an intermittent history of diarrhea. So they do get inadequate antibiotic courses, they improve, they again diarrhea. So this is 1 month is something one should keep infective colitis also. TB is less likely because of the blood, as you said, ma'am. But the more the better, the pointer for is the his growth parameters where are not age appropriate. Probably that is the thing which will prompt us to select the diagnosis of inflammatory bowel disease.
Why would somebody think of Meckel's diverticulitis? There is 7.5% people who have responded. We have 5 minutes more.
Meckel's, anyone is for Meckel's, 7% people?
So they don't present with diarrhea, they present with
Frank blood in the stools.
Blood.
Right.
So this is not the presentation at all.
So fever and blood, so those two things are there. Yeah, okay.
Next slide, please.
So now in this child, will we go ahead for scopy? And if so, then which one? Gastroscopy, ileocolonoscopy, both or none?
So we've thought of IBD. Music.
No, we can directly say.
Yeah, we could directly go for it.
How many are for gastroscopy? None. How many for ileocolonoscopy? Most of them are for ileonoscopy. How
For
many for
both?
both? Sir, why you are thinking of doing both?
We have to rule out. We are suspecting ulcerative, it will be on the lower side. If you are suspecting Crohn's, we have to get it.
So when we talk of IBD, we have to rule out both ulcerative colitis as well as Crohn's.
So entire mapping of the GI tract is required. That includes OGD scopy, that includes ileocolonoscopy, and also small bowel evaluation in terms of CT or MR angiography. So that's how we evaluate the entire system, because you know the Crohn's disease can affect any system, and that help us to select what kind of treatment we are going to get, whether the response of the patient and the later complications.
So you would do it in the same seating?
Same anesthesia.
Same anesthesia.
Vibhor, should we, like scopy will be helpful for ruling out GI tuberculosis as well?
Yes, because histopathological diagnosis is important. So from the scopy, we can take biopsies, which can be useful for a gene expert culture. At the same time, histopathology evaluation for TB and IBD. Yes, sir.
Do we do capsule endoscopy in pediatrics?
So capsule endoscopy can be done as young as 2 years of age, provided we first document the patency. It can be done. So for younger age, endoscopically we insert post pyloric capsule.
So wouldn't you go for like fecal stool
Next
cal
patient. Next slide is about that. Yeah, let's go.
The next slide. No, I think you missed one
So
slide. then.
fecal calprotectin, someone asked when we should do that. So what is the role of fecal calprotectin?
Should we first do it? Raise of hands. Is fecal calprotectin
Madam.
important in this case? Whoever says yes, please raise your hands.
For Crohn's disease, to diagnose Crohn's disease.
So in this case, ma'am, would you do it? Fecal calprotectin? Yes? Who says no for
What
it?
about infective colitis? Will it give fecal calprotectin positive or normal? Positive.
What about GI tuberculosis? Will it be positive or not?
Yes, someone
Exactly.
said that. So any GI inflammation, we will get fecal calprotectin positive. So when should we do it? Only in ruling out functional disease versus organic disease.
I would like to ask even rheumatologist and you both about P-ANCA and ANSCA, other tests, serological markers nowadays they are coming up for ulcerative colitis versus Crohn's.
So all these serological markers have certain specificity and sensitivity. So generally P-ANCA and C-ANCA are helpful when you want to differentiate ulcerative colitis and Crohn's disease depending on their distribution. If you see that almost 40% of the pediatric presentation, even from Crohn's disease and ulcerative colitis, they are pancolitis. You cannot differentiate. So at that time, it's required to choose the therapy. But for diagnosis, they don't have much diagnostic roles. Yes, it can be done, like HLA. So this test can be done. Yeah. So to summarize for the first case, as sir was requested, so whenever you are getting a short history, infective etiology will always remain a priority. When thinking for a milk protein allergy, at least 2 of the 3 systems should be there. It means the 60% of the cases, but yes, we can have a monosystem involvement and allergy as well. And milk products, soy product elimination from the diet for 2 weeks is the most logical clinical approach to start with when you are thinking of a milk protein allergy. Next slide.
Next slide.
It's time up. It's time
For
up.
this is the last slide. For the second case, the clue was anthropometry. Stool calprotectin does not have a diagnostic value in differentiating between infective GI and IBD, so don't prescribe it for the same, and detailed endoscopic evaluation is required. Yeah, thank you.
Thank you, Dr. Borg. Yeah.
Ma'am, very common.
You see
Very
it
common.
commonly.
Yes, of course it is overdiagnosed, but it's very common.
So,
Rather than it has to be animal. Whether we just say the cow milk protein allergy should be labeled as an animal milk protein allergy, the better way.
Yeah, it should be a bovine milk protein allergy. That is under consideration is a misnomer, sir.
students who have not taken the posters from the 4th floor, just go and remove the posters. I think 10 students have still not removed the posters. They would be coming and winding up those screens. And just after a small presentation of 2 minutes, the audience who gave the correct answers also come and take your gifts, and the housey winners as well. Madam there.
So, with this, we come to the end of the scientific session of Awesome EMBICON 2022. As is one of the traditions of Awesome, we always show the accounts. So we had 210 paid registrations amounting to 3,57,000, and we have added up all our major expenses, which amounts to 3,54,950. So most likely we have broken even. If there is a little plus minus, IAP Mumbai will adjust that. Thank you. If any of the delegates wishes to say something for 30 seconds, we can allow 2 or 3 delegates to say a few words. If anyone is interested to comment. Please. Mike.
We have discussed that cow milk should not be given, or any bovine milk should not be given in the first year of life. Then why IAP does not take it at government level to write it statutory warning on milk packets or on dairy or somewhere? And why app doesn't mention that cow milk should not be given or animal milk should not be given?
Madam, we'll take it up with the central IAP. Thank you.
Anybody else wants to say something? Manglani madam wants to say.
Iron and pumping, I have one question. How is this, means I have this promoting cooking in iron vessels versus this one, prophylaxis of iron and IV iron. What is better?
You want me to answer?
No, I thought the person who gave that talk is not here.
Okay. So obviously cooking in iron vessels is one message which Dr. B.C. Mehta, the doyen of hematology in this country, used to always emphasize, and he made me change my tawa from non-stick to iron to make parathas and chapatis, and I did it in my house. So I think everybody must take this cue that the traditional method of cooking was a better method, and we have shifted to Western style, which is making us iron deficient. Of course, prophylaxis presently will be required. Supplementation should be given as per NIPI program, and treat correctly whenever a patient comes. IV iron in my practice I've used only in 3 patients till date in 35 years of my practice, and I was at Sion Hospital, which was a huge number of patients. So IV iron should not be used like water. That is one message, and whether we say it has no anaphylaxis, iron sucrose still has
Please wait for 2 minutes, please. Please wait for 2 minutes, just 2 minutes.
Iron, IV, iron sucrose still has 0.06% incidence of anaphylaxis, though it is much safer compared to what we had in the past. I think this much. Thank you.
So requesting everyone to collect your prizes from Nehal for giving the right answers to the quiz. Everyone collect your prizes, and also those who won the houses, and please join us for the high tea on the ground floor. Thank
Dr.
you.
Chokhani, before you allow dispersing, before you allow people to disperse, we all will agree that awesome was awesome. And it requires 3 cheers to be raised for the organizers and of course our sir who has brought up this concept. So hip hip, hip hip, hip hip. Thank you, sir, for giving us such a wonderful, awesome. I sat through, though I don't do any more general pediatrics, but general pediatrics still is my base because hematology is not without general pediatrics. So I enjoyed every minute of the sessions today. Thank you so much. Thank you, everybody.
One last thing we'll not forget is this song, Ooh La La La.
Seriously collect your prizes for right answers from Nehal. Come. Your neighbor is watching whether you gave the right answer or no.